Several years ago, Trillium was formed, but prior to that, the community here in Lane County had a conversation about really thinking that physical and behavioral health needs needed to be met in a community-based collective environment. Trillium took that initiative up in 2014 and served two requests for proposals, one for primary care that was bringing behavioral health in, and the other was request for proposal for behavioral health organizations bringing in primary care. There was a lot of really robust interest, and eventually 8 different projects were proposed. It just happened that 4 were primary care and 4 were behavioral health based. And instead of choosing 1 or 2, Trillium decided in May and June of 2014 that they would fund all 8 of the projects. So all of a sudden there were 8 different sites, and there needed to be more formality. I was hired about that time and came in and helped the organization form the Trillium Integration Incubator project, the TIP project, so kind of creating an acronym. And we also at that time created a formality of a learning collaborative and a newsletter, an e-newsletter that has been produced weekly for the last 2 years, and an ongoing way of communicating so that there could be shared learning as these new early adopters of integrating physical and behavioral health learn from each other, and we learned from them as a health plan how we could work with them around promoting and supporting the integrated care model. So when you have physical health providers and behavioral health providers who really have worked in siloed situations, there is often confusion when you put the two folks together, like how do you do that, and what's the right way to do that, and who can do that? So in physical health, you tend to have a practitioner, a physician, nurse practitioner, or physician assistant, who is the primary biller, and there's a team around them that delivers services, a nurse, a medical assistant, a front desk person, all those people around them, but they're not billing entities. So it's really only the 3 practitioner types in primary care who typically bill. So when you bring in behavioral health providers into the physical health world, there was a set of codes and a set of billing, and how do you do that, and who does the diagnosis, and what's the chart requirement for that, and how do you match those 2 things up? So the same happened on the behavioral health side, where there was typically billing around the behavioral health services, behavioral health diagnoses and codes. Here you've brought physical health folks in. What do you bill for? How do you bill for it? How is it structured? Who can bill? So there were lots and lots of questions on both sides coming into that. So we did the best we could to make sure that people understood that the breadth of codes that they had typically billed for practitioner types could be billed and coded in the integrated environment in ways that didn't always happen before. We have a unique situation here because we, as the payer, hold both the physical health and the behavioral health benefit, so we could empower them, at least as for us as a payer, to utilize all those codes. A challenge for folks who are not in that kind of integrated payer system is there may be a payer who has a carve out for either their physical health or their behavioral health, and in those situations, it's much more difficult to discern who can be paid or who can bill and who can be paid. And every one of our sites bills across multiple payers. So the challenge was, could we do this for Trillium, but then how do we do this for our other patients? And how do we make sure that we're fairly distributing our resources and utilizing them in the right way? So there also, the structure that we use for payment for this project was a basic fee-for-service structure, but we also added for every site a per member per month additional fee to cover some of the things that aren't billed and coded and known, and startup and that kind of thing. We had a couple of, we dedicated startup dollars out of our transformation funds and also out of our own funds, and then we used our own funds, not extra funds, to pay the PMPM. So sites could do a little bit more with our resources we'd given them, but if they had a different payer who they couldn't use that same model of payment for and coding for, there was a lot of struggle for how to create workflows that were consistent and supportable and sustainable within the clinic. So we created a document that was in the integration project to help capture data that was not a typical fee-for-service coding claims kind of information. What are the things that would denote integration? Was there a huddle? Was there pre-screening of services? Was there a warm handoff between practitioners? Were there referral resources or other kinds of things that were put together? So we created a document for people to be able to track that information and really begin to understand the time and energy and person within their clinic, the staff person who would do that work. And it also gave clinics the ability to then adjust and say, I don't think that person who's independently licensed necessarily needs to do referral loop closure. Maybe I need somebody else to do that. So it gave folks an ability to look at their workforce and their work distribution. So really helping people understand where those costs might be that aren't typically captured in claim, and then how you would look at how your workforce would deliver those. Because the work is not just at the clinic level, it's at the financial level, it's at the administrative level, it's at the organizational level. The work has to keep spreading where more and more folks are supporting it for it to be sustainable. The idea was to not do a part grant that was just functional during the time of some extraordinary funding, but to try to build a sustainable model that could be replicated and utilized throughout any kind of clinic and in perpetuity. So we didn't want folks to build things only to have to dismantle it later because a funding stream dried up. About halfway through the project, we did a survey of folks involved in the project, and we asked if their daily work had improved, mostly improved, extremely improved. And 82.5% said it was mostly or extremely improved work environment for them doing integration. In a time where we have practitioner shortages and workforce burnout and folks who are really struggling with all the changes in healthcare, to have a robust outcome of more than 80% saying, "Rah, do this, keep going," and that their work life was improved, was an extraordinary outcome that we are hopeful about. But it also reinforced then to the clinics we're headed the right direction, and they were able to rally more resource and gain more support. It is accurate that 8 different projects were 8 different projects for this, and that everybody started at a different place. So there were some projects that started who'd already been doing some partnering with either other organizations or brought in staff to do some integrated work. So everybody didn't start at the same place. Other folks, as I was saying, needed to build buildings or finish clinic space. But over the course of time, there has been a coming together, kind of an evening of the playing field. We still have folks who are further along than others, and those things typically have to do with their structures or organizations or choices within the organization. But there are folks who are some of the most progressive integrated clinics that have come out of this project. And we did originally think that because we started with 8 different models, that we would end up with some models that were not successful and some that were very successful and some in the middle. What happened was it was more like everybody came up and over the hump and really made a concerted effort to pass the finish line. So it's kind of like in a classroom, everybody at least got a C, but nobody failed. And everybody's still really passionate about the work. There hasn't been, along the way I've asked about change fatigue, and they'll say, it's tough, but we still want to do it. So I think everybody's within the project has made a concerted effort to keep moving the work along, and they become more and more similar to each other, which is actually where we've evolved into now, is a much more standardized process. But folks really wanted that learning, and they would clamor and ask, how do I do it better? How do we do it better? I need to know, I want to know. And nobody said anywhere along the way, I don't want to do this anymore, or I would ever go back to practicing the way I used to.